All right, Dr. Perry, welcome to True Hope Cast. Really appreciate your time today. How are you? What is going well?
I am doing great, Simon. Thank you so much for having me. I'm really excited for our conversation today. It's actually a little bit of a rainy day here in Colorado. Normally, we have tons of sun, so it's nice to get a little reprieve and some sort of moisture up here in the mountains.
Wonderful, wonderful. I'm glad to hear that you're well. So, just as an introduction to our audience, can you just let everyone know who you are and what it is that you do?
Yep. So, like I said, my name is Dr. Perry Maynard, and I am actually a board certified chiropractic neurologist. So some might be saying, what is that? I've never heard of that. So my doctorate is in chiropractic, and then just like kind of like any specialty within healthcare, whether that be medicine, doctor of osteopathic medicine, whatever it may be, there are specialties and board certifications within those professions. So I am board certified as a chiropractic neurologist, which means that by trade, my doctorate is in chiropractic, but I went back and did a specialty and got board certified in clinical neuroscience. Very similar to what you would have in other professions, but sometimes people get a little confused when they say chiropractic neurologist. I've never heard about that. So, which is really cool because I think it might blend nicely with what we talk about later about what we do in our practice of how those things are all linked together. But my practice is here in Denver, Colorado. It's myself and Dr. Shane Stedman, and I work a majority with concussions, mild traumatic brain injuries, a lot of inner ear disorders, so things like vertigo, balance issues. Really, honestly, I tell people anything weird that goes wrong with the brain we see. So if you remember that show, it was in the US called House, where it was
Oh,
that
yeah.
kind of
I know
like
that show.
doctor who was kind of neurotic all over the place and he'd see and solve crazy cases. I always tell people we're like the house of weird neurological cases, but I like to think that both of us are a little bit more approachable than that doctor. So the crazy cases without the neuroticism. So
Awesome. I like that. Yeah. Wonderful. Amazing show. When I studied nutrition and we had a lot of anatomy, physiology, and Western medicine, I would call that my like junk studying sessions, watching House episodes. And
yep,
yeah,
that's awesome.
it certainly takes a British actor to pull off the to pull off the wild character.
Yeah.
But that's really cool. So you did your doctorate for about 7 years, and then you went back to do neuroscience. Like, why? Like, what happened when you were done? Did you see gaps in the studies, or did you just like know that's kind of where you wanted to go and you needed to fill in some information? Like, why did you kind of go back to study that?
Yeah, no, great question. So originally in college, I was a pre-med major with a biology major with a minor in neuroscience. So I had always been just kind of interested in the brain. And I think people always get interested in things when there's weird things about themselves, ever since I was kind of like younger. But another big piece was I played Division 1 football. So I played football my entire life. So part of it also was selfishly, as I finished up my career, I started to see teammates on disability at 25 years old, having debilitating seizures, having teammates die of seizures secondary to head injuries. So I think selfishly, we all get into things because we want to kind of help ourselves and figure out, what's going on in my brain and, how do I keep from being 50 and not knowing who I am or not knowing who my, wife or children are. Plus I just always found the brain very fascinating. But either way, originally when I went to school, I really just wanted to do sports medicine. I loved the manual therapy aspect of chiropractic. I loved the manipulation, the adjustment, but I also loved the rehab. I love that I could be kind of a hybrid of a PT and a chiro, which honestly you're seeing more where you're seeing PTs and chiros that are very similar and do very similar good work. So that's originally what I wanted to get into. And then while I was in school, I got exposed to a Dr. Ted Carrick, who some would say is the godfather of functional neurology. So Ted Carrick is also a chiropractic neurologist. He got his fame when he worked with Sidney Crosby back in the day. So he was one of the main doctors who got Sidney Crosby back playing again from his concussion. So that's where he got a lot of his fame, but kind of the godfather of functional neurology. And I listened to him speak when I actually was at the NFL Combine, and I was like, wow, this is really cool. I didn't think I'd ever be able to use any of this. Like I learned it in undergrad and I'm going to chiropractic school and you're telling me I can do something with this neuroscience degree, or I can do things to change brain function. This is really cool. So I got involved heavily with the Carrick Institute when I was in school, and I started taking courses. I took over probably 400 hours of continuing ed while I was in chiropractic school because I knew this is what I wanted to do. So probably about like a year into chiro school, I was like, this is what I want to do. And then I had the fortunate ability to work with a Dr. Glenn Zelensky, who is an amazing clinician up in Portland, Oregon. He's got one of the best clinics, I think, in the world. So I did my residency up there and worked up there for a little bit. And it was once I was immersed in it that I was kind of like, this is what I want to do. I love chiropractic and I love the manual therapy side, but I personally was like, I don't want to be just treating low back pain and neck pain. I don't. It didn't fascinate me. Versus realizing like, wow, I can take people with complex neurological conditions and I can do something to change them. Especially because traditionally there's nothing that's offered for these individuals besides medication, therapy, and sometimes physical therapy.
Can you explain to us a little bit how a manual adjustment in a chiropractic
Mhm.
session can influence and change your nervous system? And I think with that question, if you want to begin with maybe giving us a foundational explanation of like maybe what the nervous system is.
Mhm.
I think that I think when most people think of the nervous system, we think of like, the sensations and the feelings that we have, whether that's our like peripheral nervous system or our central nervous system.
Mhm.
But I don't think we're really taught too much about like the differences between the two.
Mhm.
And then if you could blend that into how an adjustment can, significantly change the way your nervous system like functions or how you experience pain, etc. Do you think you could do that
Yeah.
for me?
For sure. No, that's a great question. And I'm going to try to unpack stuff in the simplest form.
All right.
When you're looking at the nervous system, let's say, like you said, traditionally it's split up into what's called the central nervous system and the peripheral nervous system. So the peripheral nervous system is everything outside, in essence, the spinal cord. So the nerve coming from the spinal cord to, let's say, my bicep. We have a motor nerve, which causes contraction of a muscle. And we have a sensory nerve that gives us feedback of sensations, all sorts of sensations. So, like vibration, kinesthetic awareness, like where a joint is, which is going to be really important when it comes to adjustments, temperature, hot versus cold, right? So, all of these different types of sensation are constantly being fed into my spinal cord and up into my brain to say, here's where my arm is. So, traditionally, when we think of the peripheral nervous system, people think about like neuropathies. So someone's got like a diabetic neuropathy, the nerves in their hands are dying, so they get this like numbness and tingling. Or maybe I have a herniated disc in my neck, it's pinching on a nerve, and that's what's creating this radiating pain, right? That's the peripheral nervous system. A lot of what we do is more affect the central nervous system. So there's a lot we can do to affect the peripheral, but when we're thinking about central, it is everything from the spinal cord, right? So the cord inside my spine up into the top of my brain. Now, I think the best way to explain this, the question is there's so many different areas of the brain, right? We have the spinal cord. We have what's called the brain stem, which is where a lot of automated reflexes live. So balance, regulation of heart rate, respiration, my ability to sweat, my ability to dilate my pupils, right? All of these things that are automated that we don't really think about. Okay. And then we go a little bit step higher into what are called subcortical areas. So sub below my cortex, right? Which is like the big hemispheres everyone thinks about. Subcortical circuits are circuits that play a huge role in regulating. Think of them as like the symphony coordinator. They regulate to make all these reflexes are working appropriately. So if we kind of think of the brain, we could think of it this way of there's a controlled object, which is let's say my hand. Well, that muscle has a controller and it's the nerve. And that nerve has a controller, it's my spinal cord. And that spinal cord has a controller, it's my brainstem. And that brainstem has a controller. And see, it goes up and up, right? So there's hierarchy. There's these primitive reflexes, and then ultimately there's this executive part of my brain, which people call our frontal lobe or our prefrontal cortex, which really just makes sure all of this works, which is cool because we have redundancy. But you could have someone that could have a issue in their brainstem, but if their frontal lobe works appropriately, they can make up for that, right? So it's all of these different levels and hierarchies. But at the end of the day, the argument of like, what's the point of a brain is an interesting question, right? Everyone's got their different theories, but there's a lot of theories that I think make sense of. One of the basic foundations of the brain is to be able to explore our environment. A big part of our brain is to understand the world around us so that we can interact with our world. And this is why we see that so much of the brain has to do with interpreting sensation, right? So like we said, touch to my hand. Where is my wrist in space? So is it here? Is it here? Is it here? Where's my head? Where's my head relative to my body? Where am I in gravity? So how is my inner ear interpreting where my head is in the world? And then how is my vision telling me where's the world in reference to me? Honestly, that is some of the biggest function that the brain plays a role. All of these other things like appreciation for art, for music, for having relationships, for being able to be empathetic, those are all like the icing on the cake in this higher order area. But what you see is that when these other things start failing, the brain preferentially throws out those other things to try to fix your sensory awareness. And this is why I see concussion patients with dizziness and balance issues develop depression, anxiety, mood disorders, and then you fix their balance issues and those things get better, right? Because the brain says, hey, my priority is to make sure you don't fall. Who cares if you enjoy music anymore? Who cares if you know your neighbor's name? You know what I mean? Those things, those aren't life and death. Those are like if everything else is working appropriately, you know? So that's kind of, I hope that's helpful in giving an idea of central versus peripheral. So if we're talking about adjustments, let's talk about how adjustments can affect the periphery. So everything from pain to central things. So if we're thinking about an adjustment, really some of the theories are looking at an adjustment is you have different types of adjustment, but let's take a high velocity, what people think of like someone cracking their neck, right? So you have a quick accelerated movement through a joint. So one of the first things that's happening is that one, you're stimulating receptors within joints called mechanoreceptors. So within all of our joints, we have what are called mechanoreceptors. And this is what tells me my head is slightly right, farther right, or it's left, because they're kind of these hair cells that displace. And this is a big reason why individuals who have whiplash injuries a lot of times will get dizziness from their neck, because those receptors no longer give good feedback. So those mechanoreceptors give feedback to my brain to say, here's where my joint is in space. So we know when we adjust, we heavily affect those mechanoreceptors, but we also affect the tone of muscles. So another way that my brain knows where a joint is in space is that when my wrist is like this muscle is short, this is long. And then I match that with the mechanoreceptors. I match that with the stretch on my skin and the fascia to say, here's where my hand is in space. So from a local standpoint, an adjustment is going to affect the skin receptors, the mechanoreceptors, but it's going to alter muscle tone around a joint and sometimes can normalize muscle tone, giving better feedback. So there is a researcher named Heidi Havoc, I think out of Australia, I think. She's got some really cool research in the chiropractic realm on how adjustments affect brain function. And she's got a cool analogy that I'm going to steal, but think of each segment of your spine or each vertebra as a camera, okay? And that camera gives feedback of where that joint is in space. When a joint becomes fixated or stops moving, so let's say I have this wrist, and normally my motion is that much motion, and then I get an injury and now it's this much motion, I'm depriving the brain of this much information and I'm only giving it this much. So let's say my neck is really tight, the joint's not moving, it can't feed information back up into the brain to compare to say, does it match my inner ear and my vision? So when you look at an adjustment, it's got local effects on the mechanoreceptors and the muscles, but by reinstating normal function in a joint, you improve the feedback to the brain. I always tell patients it's like, especially in whiplash, your neck is like a radio station in like Arkansas in the middle of nowhere. Like you got like two stations and it's like a Christian like gospel station and like a talk radio. Otherwise, every other station is just pure static. And so an adjustment or work to the neck helps to tune to where that station is now clear. So that when my head is turned here, I can now get matching signals from my inner ear, my vision, and my neck versus if my muscles are tight, telling me that my neck is to the left, but then I turn my head to the right and my inner ear says, you turned your head to the right, that's where people get nauseous and dizzy. So adjustments help all these local things, but then play a huge role in helping to remap where the body's in space. So I look at adjustments as if I want to remap someone's body awareness, adjustment is powerful. So once again, if I have a wrist injury, the more I can manipulate something, the more I'm going to drive feedback. And so going back to your question about pain, there's a few different theories. There's the pure like gait theory of pain. Like if I have a burn, right, what do? I instantly rub it. And that's because proprioception, right, which is just touch, vibration, all of those things, actually inhibits pain at the spinal cord level. So we have pain circuits that we can inhibit at the spinal cord level, which chiropractic adjustments have been shown to be able to gate pain at the spinal cord level. But Heidi Havoc also has some really interesting research showing that you improve motor control of joints. So there's a top down, right? So if I have this wrist and it's kind of like doesn't move very well and I adjust it, it improves the motor control, i.e. the way my brain now controls that limb, which then can help with pain, can help with smoothing out movement or to make movement more coordination, and improve, in essence, the latency for the time for a muscle to contract. So example is I got a shoulder that dislocates a little bit more than I like. And I've had multiple surgeries from football, and I love doing Brazilian Jiu-Jitsu. Not the most friendly thing on joints. So one of the big problems that I have is that I have no internal stability, so that when someone goes to hit my arm and I get movement, that movement should be picked up by muscles and sensors in my shoulder, feedback to my brain, and if I'm really fast, I stabilize really quickly, right? This is like if you ever have someone you're testing balance and you push them and you see how quick can they respond. You're looking at how fast is that signal from the muscle to the brain to then control it. So going back to doing things with adjustments or chiropractic can improve that latency. So now my shoulder can better respond to a perturbation than maybe it did before.
That's interesting. And I think some of the big points I've picked up there is that hierarchy, that kind of cascade event that you're talking about, those different levels of experience and neurological function. And I'm sure that's mimicked in the body in many other types of like parallel pathways, especially like the kind of hormonal system from like your brain down to your ovaries or testes. You know, you have these different structures, they're all dependent on each other. They might be kind of maybe working independently of one another, but like they're all in relation with each other. You know, I'm sure they're all communicating and they rely on each other to get like let's say the full picture. And it really makes me think about when you're talking about that, and it was, you know, it's complex. If you have no idea about, you know, neurology or anything or biology, it could be difficult to understand. So I would recommend like maybe going back 10 minutes and listening to that again, because it's really, really a wonderful explanation. And it really makes me think about how, because that's so complex in so many different areas, and there's many mechanisms that, you know, help us create our reality through kind of our nervous system and our senses, etc. It makes me understand how it's so difficult for people to not understand like the energies and kind of mystical things around us that we can't actually see but are there. Like, you know, you got the examples of like, you know, like bees and flies and butterflies see things in the physical world that are completely different to us. And I'm just thinking about like energy and frequency and all these other things that shape this wonderful world that we're in. And it makes me understand a little bit more how many people might not understand that, considering how like complex our nervous system is, to allow us to kind of stay safe in our environment and you know, get away from things if we need to, because we have this physical body, we have this mind, and we have this complex nervous system to make us like do that. It's just, that's very, very cool. So I appreciate you kind of sparking that thought process for me. I have a question in regards to, you were talking about like if you have a wrist injury, you know, say you've got 100% full movement in your wrist, and you have this injury, and let's say you've got 25% movement. Is there any research in regards to actually just not attempt? Well, if you can only move 25%, what about thinking about doing the whole movement? Because obviously, like, there's a connection between what your body mechanistically can actually physically do with your wrist and your muscles, ligaments, tendons, etc. And then your brain obviously has got the comprehension of doing the full movement. So is there any research in regards to actually just not doing it, but thinking about doing that full range of movement to help the actual wrist heal?
Yeah, no, that's a great point. Then there definitely is. There's a lot of cool research looking at how visualization can light up all the pathways all the way up to the spinal cord. So everything from, because your brain is all about, so you have, if we think about movement, we have what is called a feed forward mechanism, which is that subconsciously, I think I want water. My brain has rehearsed that like a dozen times before it even becomes conscious to me. Okay. And so my frontal lobe and my cerebellum, they work kind of in opposite. So let's say we're talking about reaching my water bottle on the left. My right frontal lobe, or my right side of my brain, controls my left arm. Okay. And so I say, I want to grab this water bottle. Well, they feed back and forth, and the frontal lobe says, hey, I'm just about goal directed behavior. Like, I just want to do this. And the cerebellum and another part of our brain called our basal ganglia, they have the filing cabinet of how do you do it successfully? How do you coordinate the appropriate muscles to make it happen smoothly? So they go back and forth a dozen or so times, and then all of a sudden they say, okay, frontal lobe, here's what we're going to do. And then they send that signal to my spinal cord and everywhere else in the nervous system to say, here's the plan. So when you get feedback for doing the plan, let me know if you're correct or not. So when I go to reach for this water bottle, I'm getting feedback from my entire arm, and I'm saying, does that match what I pre-predicted, right? And if it does, I get a little bit of dopamine, and it says, that was a great job, do that again. If I don't, and let's say I reach for this water bottle and I miss it, or I get a little bit of a tremor, right? And ultimately, this is where you see things like tremors or movement disorders, is there's a breakdown in selecting the appropriate movement pattern. So going back to visualization, is that visualization lights everything else up into that point, right? So it doesn't necessarily make the movement happen, but it can prime those circuits, because we know that, like, when injuries are casted, or we even know with low back pain that we get cortical smudging. I don't know why I'm blanking on the gentleman, the two gentlemen who wrote one of the early pain science books. But either way, it might come to me. But they were the ones that kind of popularized this idea of cortical smudging, which in essence is when there is chronic pain or disuse of a limb, your representation of that limb starts to, in essence, go away. If you don't use it, you do lose it. And this is why there's some interesting studies looking at when individuals are casted, being able to maintain a certain amount of muscle mass compared to control subjects. So there's clearly something even happening on a physiological standpoint in the muscle, that individuals who didn't do any visualization lost more muscle mass than individuals who did. So it's kind of like you're priming that circuit neurologically, everyone just thinks muscle. Everyone thinks rehab. I got to make that muscle stronger and bigger, but they forget that strength is really your brain's ability to recruit motor units, right? So it is a strength and power and explosiveness is 100% a neurological event. Yes, you need the muscle, but you need your brain as well. So what's also cool about that as well is that we'll use that a lot of times in individuals with pain. So if someone's got a wrist and it hurts to move, by visualizing pain-free ranges of motion, you can start to train them that that's no longer a threat, right? And that's where things like mirror therapy play a role, right? Mirror therapy uses certain circuits as well, where you're getting visual feedback as if your limb is moving, but it's not actually moving. So that's where I think things like mirror therapy and visualization are super cool. And there is definitely some cool research on those.
Yeah, I just know there's research in regards to, how you can create matter through thoughts. Like you can just think about doing a bicep curl, and they've done studies where they see, like, it might be small, like maybe 5 or even just 10% of like that muscle growth, but it's just amazing
Mhm.
that you can think about doing the actual movement without doing it and actually getting some of the actual physical benefits. I think it's really, really fascinating, to be honest. Yeah,
Mhm.
it's very, very cool stuff. I'm
Yeah.
just not sure if it had been done with, like broken or damaged tissue that needs to be healing. But it makes sense to me that,
Yeah.
if I have a particular injury or anything, and I've got the time and space to meditate,
Mhm.
I put my focus and I put my awareness on that particular area, and I know that that's, where I put my attention is where I put my energy. So I
Mhm.
think that's a very cool aspect of it as well. You mentioned something about balance issues and depression.
Mhm.
Is that like can you take us through that connection? Because
Yeah.
yeah, I think that's very interesting. We've got so many mental health issues going on around the world. We all experience depressive thoughts and
Yeah.
anxious thoughts, and for a lot of people that can be constant. It can be chronic, but like,
Yep.
is that sometimes connected to just, like, balance issues?
Yeah, that's a great question. I think, when you look at depression, right? We've always tried to nail it down to one simple mechanism. As you saw recently, kind of the serotonin hypothesis is we finally realized it's more complex than that.
Yeah.
And now you're seeing a lot of people talk about it from a inflammatory model, which I think is correct as well. I think where you see this become relevant is in concussions and vestibular disorders or inner ear disorders. And so there's a few different theories. So to answer your question, yes, you see all the time when people have concussions and they have alterations to visual processing, auditory processing, balance, all of these things, and they're depressed and anxious, and you think, why those two aren't related, and you improve their visual processing, their balance, those things, it's not uncommon that you see things like mood get better. And the question is, like, why would that happen? Few different reasons. So some of those things are controlled by the same area of the brain. So this is work out of a gentleman named Jeffrey Shamaman, and he's out of Harvard, out of Mass General. And all of his research is on the cerebellum and affective disorders. So cerebellum is a part of our brain that sits underneath here in the base of my skull, and it has everything to do with coordinating movement. So we've always thought about it as coordinating movement. So like my ability to do, right, these rapid alternating movements, my ability to coordinate balance, my ability to coordinate we've always thought about it in a motor sense, right? Coordinating movement. But what Jeffrey Shamaman has shown is that it not only coordinates movement, but it coordinates thoughts and emotions, right? Because they're all the same loops, they're just different contexts, right? Because a thought is a motor response. We don't think of it that way because there's not a muscle involved, but it is an expression of self, right? It is an expression of let's say it this way, it's an expression of a signal. So this is an expression of a signal and it's a movement. My thought of being happy is an expression, but just a feeling. And so that cerebellum that also has to do with coordinating balance also coordinates mood. So in some cases, it's just that same area is affected. So vestibular disorders affect the cerebellum. Concussions are notorious for affecting the cerebellum. Strokes are notorious for affecting the cerebellum. And that's where you can see some of those mood disorders. I think the last piece is, think about, I explain it to patients this way. So think of my cerebellum as being in charge of all the basic chores of the house like kids should do. Let's say take out the garbage, mow the lawn, empty the dishwasher, right? Or that, like my wife might say, is my job as well. And I still
Okay.
fail sometimes, right? So that's the job of the kids, right? And the job of the parents is to go to work, pay the bills, make sure all the really important things are done, right? But all of a sudden, let's say the kids decide to stop working for the day, right? And they're like, I'm not going to empty the dishwasher. I'm not going to do any of these things. And so mom and dad come home and they say, now I have to do extra work on top of what I was doing before. No one, no one else is going to mow the lawn. Okay, I need to do that. And so what happens is you take resources from your executive brain, right, where depression comes from. So depression comes from your prefrontal cortex or lack of function there. And so you move all of your energy to make sure that you don't fall and you don't get dizzy, that there's no energy left to go towards mood. So think of it as like allocation of resources. And in concussions, the brain becomes very inefficient, and it's very inefficient in how it allocates energy and currency. So then you may feel okay, and then you go to work for 4 hours and you're like, I'm so anxious, or I'm wildly depressed, or the things I used to love doing, I no longer love doing. Why is this happening? They have no juice left in that prefrontal cortex because it's spending all of its time to sort out why you fall every time you stand up or every time you try to go down the stairs. Think about it. Walking down the stairs, you shouldn't think twice about it. It should be a piece of cake. In a lot of my patients, they literally have to consciously think, how do I take a step? Right. And so there's no energy left to do these higher order things like mood, right? Because at the end of the day, if your brain thinks it's going to fall, it doesn't care if you're happy or you're sad. It just cares about you not falling. So that's kind of how I look at the connection between some of these sensory processing issues like balance and then things like mood.
Very interesting. That resource allocation piece is very fascinating because
Mhm.
that again extends to many different systems within the body. I think of digestion primarily, like if you're super
Mhm.
stressed out and you've got all these other things going on that you may even just be you may just be unconscious about, your body's still having to deal with those things, and then it can't, it's unable to do the normal things of breaking food down and making nutrition for you. So then you might have some digestive things come through. So yeah, that makes total sense to me. Thank you for that explanation. Have you, with the last couple of years of wild stuff going on in the world, have you seen any like common issues coming through the door? Like we've seen so many people like depressed and anxious and
Mhm.
stressed out through COVID lockdowns,
Mhm.
mandates, etc. A lot of stressed out individuals. Have you seen like more of a certain condition coming in, or people coming in with new stuff coming in? Is it of any patterns you've noticed in the last couple of years?
Yeah, actually, we Dr. Stedman and I, who I know you chatted with a few weeks ago, we were talking about this. A huge influx of patients with what is called dysautonomia. Most specifically, what people know it by is what's called POTS, POTS, and it stands for postural, so posture, orthostatic, so changing position relative to gravity, postural orthostatic tachycardia syndrome, right? This is in essence where individuals stand and they either pass out, they feel like they're going to pass out, they stand up and their heart goes to like 120 beats per minute. And the hard part about POTS is that the best way I ever heard it explained is that the symptoms that people have with POTS is like your worst hangover, right? Nausea, diarrhea, stomach hurts, I have a headache, I have brain fog, I feel dizzy, I feel faint, right? And so the problem with these individuals is that they get thrown to all these different specialists of, okay, you have GI issues, so you have nausea and diarrhea, go to a GI doctor. Okay, you have joint pain, go to the rheumatologist. Okay, you have dizziness and migraines, go to the neurologist. Oh, your heart's racing fast, go to the cardiologist. but it's all coming, like we may talk about, it's all coming from one etiology or one area. So I'm seeing a massive influx in dysautonomia patients, which in essence is an inability to regulate one's autonomic nervous system or automated nervous system. So there's a part of our nervous system that is fully automated that regulates my breathing rate. So my inhale, my exhale, my heart rate. So the rate, the rhythm, how hard my heart contracts, my blood pressure, the saliva in my eyes, the mucus in my mouth, my ability to sweat, my ability to regulate temperature, all of these things that we never think about. My ability to control how much my gut moves, right? So, how long does it take for me to have a bowel movement? So, if people are constipated or have maybe more frequent bowel movements, all of this is controlled by the autonomic nervous system. And so, dysautonomia is a disorder that causes that to not work. And so we've been seeing a massive influx. And I think a lot of this is secondary to COVID because dysautonomia is notorious to happen post like viral infection. So it's kind of, it's not funny, but you're finally seeing the medical establishment believe that infections can cause serious issues. So I have a lot of Lyme patients. So I have a lot of Lyme disease patients who have been suffering for decades and no one has ever believed them. Right. And things like Lyme disease can cause things like this. But COVID has finally opened the healthcare arena's eyes and like, oh, wow, infectious diseases don't just cause like coughs and sore throats, right? They can affect our brain and our neurology. So I think that's honestly a big reason why I've been seeing a lot of dysautonomia. Um, so I think early on, maybe a huge influx in anxiety. Like Dr. Stedman and I talked about, I think COVID and the lockdowns just brought out people who are already anxious. So people who already had a tendency to be anxious, you lock them up in a house for 2 years, that anxiety is going to multiply. So we've definitely seen an increase in anxiety, depression, but the biggest thing I'd say is that dysautonomia, or more specifically, POTS cases.
Interesting. Yeah, well, it makes sense. I mean, you've got like herpes viruses, that hang out in cranial nerves. So I don't know too much about like why viruses like nerve tissues. Have you got any? Can you explain that at all? Is there any thought processes
Yeah,
behind that?
that's a great question. I don't know if I actually have a great answer for that. I know I have heard individuals discuss. I mean, so when you look at, let's take either certain viruses or spirochetes, right? A
Mm,
lot of times their goal is to not kill you, right? They want you to be their host. If if a virus or a bacteria kills you, it's not going to do a very good job of being able to transmit to another host. So a lot of times viruses will hide in places that are very hidden from the immune system. So sometimes like joint tissue, so synovium within joints, but a lot of times in nervous tissue as well to try to hide from the immune system. So that's part of the reason why is or theorized, especially in like Lyme disease, is that it will change forms. So it will go from being what's called like a cell wall form, so being in the cell wall, to a cyst form. So it literally it will morph. So some of these things morph and they move into different tissues with the whole goal, in essence, is to evade the immune system. So that's why a lot of these things will lay down in brain tissue, is that traditionally the brain is thought of being separate from the rest of our immune system,
right.
right? That's the point of the blood-brain barrier. As we're learning, that's not totally the case. And there is connections between my body and my brain and viruses being able to get in there. But when we have viruses or inflammation or concussion, that breakdowns our blood-brain barrier. So now sometimes a virus that's in my body can transmit now into my brain. So there's multiple mechanisms. So sometimes I think it's just how a certain bacteria or virus works. It preferentially, it may like an area that's highly metabolic. So the brain is highly metabolic. So like take cancers, for example, right? So cancers may happen in certain tissues because they're highly metabolic or they turn over very frequently or they don't turn over frequently. So I think there's individually to certain infections, but sometimes infections end up there because of inflammation and they're floating in my bloodstream. And then all of a sudden you open up the barrier system and they're like, whoop, here they come. And then they
Yeah.
end up in the brain, which is very common to see post-concussion.
Yeah, it's a very interesting idea, like looking at like, what a virus or what a bacteria, actually like under a microscope looks like. You can take the spirocheta, excuse me, bacteria, which responsible for Lyme's
Mhm.
disease, and you can actually look at that under a microscope. And I'm pretty sure the etymology of spirocheta is something like spiral long hair, and you can look at it and you can tell
Mhm.
that that bacteria, it's very, very cool, is designed to evade something, the way that it's
Mhm.
built to coil in and embed
Yeah.
itself and do its thing. It's actually, if you were
Burrow
to,
real deep into tissues.
if you look aside of the traumatic things it does to people in the long term, it's actually quite remarkable actions from like a microorganism. It's actually very, very cool. But yeah, it's very interesting to see how it kind of like looks to work symbiotically with this very complex um, nervous system and different systems that we have that are obviously very, very ancient and have worked with and against microorganisms for a very, very long time. We're going to switch things up a bit because that was awesome. Thank you for that.
Yeah.
I want to talk about sports rehab a little bit. So can you tell us how neuroscience plays a role in sports rehab?
Yeah, no, that's super cool topic, and I was with another sports chiro that's in Denver, and he works with a lot of the pro teams, and we kind of play around with that. I think, like we talked about earlier, I think traditional rehab has always been thought from a musculoskeletal, or you have a, let's say, an ankle injury. Let's ice, let's stem, let's do all these local things to the ankle, right? And then let's do things to strengthen it, but thinking of it from a just strengthening the muscle versus maybe the connection. So going back to, like, let's take an ankle sprain. So we know an ankle sprain happens. Let's say there's stretching of like ligaments, tendons, maybe like a bunch of micro tears. There is changes to, say, like joint capsules, things like that. So there's a local event that occurs, which of course needs to be taken care of, right? We have inflammation that comes in to stimulate the immune system to then clean out dead debris. But then ultimately we want to bring things in that are healing. So we have a metabolic aspect to an injury, which is definitely important to control. But like we talked about earlier, if I stretch all of a sudden a ligament, or I stretch a tendon, or I affect the joint mechanoreceptors, well, now the feedback that that joint is giving to my brain is inadequate. And so now we may notice that, like we talked about, the latency. So going back to ankle control. So if I'm on an unstable surface and I'm moving, when as soon as my ankle turns, how we have to think about how much movement has to be displaced before my brain gets it. So if here's my ankle and then here's fully inverted, ideally I want a micro movement and then I can recover. But if there's a stretch and there's bad feedback from my joint to my brain, maybe I have to go all the way to here before all of a sudden I snap it back in.
Mhm.
So from the neurology standpoint, there is becoming more in saying we need to do things to rehab things like proprioception, right? Or kinesthetic awareness. We can't just rely on just strengthening the muscle. We have to improve, one, the mind body connection between that joint and the brain, but then we need to do things to improve the motor control, or how quickly I can detect a change in position, get my brain to understand that feedback, and then correct it. So I think that's one big piece when you're looking at rehab and neuroscience. Another way, so there's actually, and this would be a great, and I can always put you in contact. There's a great group out of the States, but they teach all around the country, called FNOR. So it stands for Functional Neurological Orthopedic Rehabilitation. It's taught by a guy named David George and Stuart Fife. Stuart Fife is a PT. I want to say either I think out of the he might be out of the UK. And then David George is a chiropractor and a nurse practitioner. They developed an amazing course that's all targeted towards rehab, but a neurocentric standpoint. So it's all targeted towards chronic pain. So what's interesting is, let's take like an isometric contraction. right? So isometrics are used a ton, right? So for individuals who don't know, an isometric contraction, in essence, is a contraction where there's really no movement in a joint. So my wrist is here. If I push it this way, so if I'm pushing my hand and it's not moving, that is an isometric contraction. So my muscles are contracting, but there's no movement or change in the joint. Okay. What's really cool and what they've shown is that isometric contraction, but not just short, but intense bouts of isometric contractions can do a few different things. One is they can have an analgesic effect or a pain modulating effect. So isometrics for like multiple minutes can have pain modulating effects. That's one thing. The other cool thing is that they've shown that you can improve cortical smudging with isometrics. So minute and minute plus long isometrics help to re-groove out that representation of the limb. So what's really cool is that different types of muscle contraction, so an isometric versus, let's say, an eccentric, can have different effects on the brain. So when we're looking at an eccentric, that might be like as I'm bringing the barbell down on a bench press, it's the descent down to my chest, right? That is me controlling a weight. Eccentrics have been shown to heavily influence another part of our brain called our basal ganglia and our cerebellum. Once again, like we talked about, that has to do with controlling movement. So there's a lot of cool things of using actually eccentrics in Parkinson's patients. So I'll use a ton of eccentric or slow controlled movement because that helps to give better feedback of that limb. So you can see where we can use isometrics to stimulate different areas of the brain. We can use eccentrics to stimulate different parts of the brain. And then we can do things where you look at, so going back to movement, when we think about moving, we have internally generated movement, or we may have visually guided directed movement. So take a Parkinson's patient, for example. They have a really hard time internally generating movement. That's why one of the tests is a sit to stand test. So it's saying stand from this chair, walk over there. And they're terribly slow at doing it. And part of it is because the circuits in the brain that internally say go move aren't working. But if you have a Parkinson's patient and you give them like a laser target, they move way quicker. So like Parkinson's patients will freeze when you get to like a door frame. If you give them something to step over, they can step over no problem because you're giving them a visually guided movement. That uses a different motor loop. So part of the time is finding the loops in the brain that don't work and either fixing them or finding another way to make it happen. Now, I know this goes far beyond sports rehab of what people are probably thinking about from like a low back injury, but it can be taken all the way to the rehabilitation of someone like with Parkinson's, because at the end of the day, it's all just a spectrum. A stroke in Parkinson's is just a spectrum similar to low back pain in that there's altered things going on in our nervous system. It may have started with a mechanical injury, but it now has become a neurological phenomenon. So you can use those same principles kind of towards each other, if that kind of makes sense. And I know I might have gone on a little bit of a tangent of some things, but I hope that that helps to show that there's so many ways that you can use these things that are traditionally thought of in physical therapy that are muscle centric, but they have huge impacts on the nervous system and on the brain.
Is that a conventional thought process in regards to somebody coming in who needs rehab, like to think about that type of way of looking at it? Or is that alternative? Is that complementary? Is that something you have to, you have to go to, you do your chiropractic doctorate and then you go back and do neuroscience type of thing? Or, or is that something that usually happens within like a conventional setting, or is that a bit out there?
Yeah, no, I would say no, it's getting there. It's the research is there. The research is there, clinicians and their ability to catch up or for schools to really implement it. It's getting there, but it's not. If you go to your traditional PCP or standard ortho, right, they're still heavily focused on the patho anatomical model, right? Which means you have a disc bulge. That's why that's why your back's a mess. Or
Yeah. Okay.
look at this DJD or this degenerative joint disease. That's why you have low back pain. And no one's looking at, well, how does this person move? How do they stabilize? What's the motor control of their low back? Do they have control over their hip, over their ankle? That's something we didn't chat about too, is looking at the whole kinetic chain, which in essence is how well can my, if we think about my low back isn't really set up for movement. The way that the joints in the spine are set up is really for like forward and backwards motion. The lumbar spine is not mechanically meant to get a ton of movement or a ton of rotation. My thoracic spine, so my spine above, and my hips are far more mobile. And so those are where I might get a little bit more mobility. And individual, why am I blanking? Gray Cook is kind of the ones who popularized this. Gray Cook is a PT out of the US who started what's called FMS, SFMA. He started with that concept of areas of mobility, areas of stability. So going back to the low back is, I really look at the low back as how well can it transfer load. So if I'm throwing a ball, I need to transmit force from my legs to my arm. What does that is a stable canister in my abdominal wall to be able to transmit that force. So going back to, it's getting there, but a lot of people don't. A lot of people say, you have a disc, let's give you medications for the pain, let's ice, let's rest. When really I'm going to make the argument, the faster you can load a tissue and get someone active again, the better. So I've kind of changed my tune heavily where, going back to, let's take my own example of shoulder dislocation, I was loading it with 20 minutes worth of isometrics the next day after I had it dislocated for 3 hours in the hospital, right? Most people would put you in a sling and they say, don't move it for a few weeks, ice it. And the doc that I work with, that we work together on a lot of sports cases, I was like, well, no, because I, one, want to keep the muscle strong, but two, I want to keep my brain's awareness of that joint to work. And three, I want to create an analgesic effect. So literally, I would load it in different planes isometrically because I don't really want to stress the joint, but I can feed my brain information just like the visualization, say, hey, your shoulder's still here. It's still stable. Let's take care of it. Let's heal it faster. So I think that's really the paradigm of using neuroscience in rehab, is getting away from the let's rest and ice to like, how do we load this joint safely as quick as possible so that we can heal it and we can create or keep from the least amount of atrophy, not only in the muscle, but atrophy in the brain as well.
Very cool. Yeah, I think that's it's a very interesting way of looking at things, and you have to obviously looking at a root cause. And obviously, just if you blow your knee out playing football, or you sprain your ankle or whatever, you go and see your primary care practitioner. Mm-hmm. They're going to be narrowed in on that particular area. They might not be looking at like, what's your pelvis doing, what's your spine doing, yep. what's the top of your spine doing. I know for me personally, I've done my knee. I've done my right knee a few times on the medial side. Mm-hmm. And like the third time I did it, it's usually 6 months out of playing soccer for me when I do it. I've done it 3 times in the last like 7 years. And the last time I did it, I went and saw a chiropractor about it because I just felt I felt like it just wasn't my knee that was the problem, because every time I've gone to see someone, it was always my knee, it was my kney. Mm-hmm. And then I started working with a chiropractor, and it was quite clear there was something I was doing every day, like a million times, like little bits that was like compounding to shift my pelvis up, and then I ended up finding out that my left glute gets ridiculously tight, my right hip flexor gets ridiculously tight, twists my pelvis up, creates really a lot of tension on my quad here, mm-hmm. which creates that tension like an elastic band. So when I'm playing football and I'm going to go in and like do like a passing movement or like going in for a tackle, it's just like kind of an injury just like waiting to happen. But without being able to like step back and actually figure out that, okay, my problem is that I have really tight muscles in different areas that I'm not knowing, and it's functionally changing my body in really subtle ways that mm-hmm. build up to create a big problem. So I'd have lower back issues as well, along with the knee pain, and I didn't connect that until I started speaking with my really experienced chiropractor. And now, as long as I stretch out my glutes, as long as I stretch out my hip flexors and my hamstrings and my calves as well, then I have absolutely no problems. And it's just very interesting because not a lot of people will get to that point, and I can guarantee 99 times out of 100, you go and speak to your doctor about like your knee injury that you had, you'd never ever get to the point of like looking at like where your pelvis would be unless you got to a really forward-thinking functional practitioner. And it just feels that there's so many holes in the conventional idea of like what an injury is. And when you're talking about your shoulder as well, where you would have it cast up, or you'd have it like in a sling or a broken leg, like the first thing you do is like they cast it up and stop movement, ice it, like trying to take the pain away, rather than thinking about like your leg is much more than your leg. It's like it's your pelvis, it's all these other things. And I remember listening to a Brett Weinstein podcast talking about how his son broke his leg, and he they didn't cast up or anything. They wanted him to get moving with it as much as possible, even if it was just thinking about movement, or if it was just micro movement, or doing isometric like strength training in and around it, how that can just benefit in so many different ways in regards to this whole idea of like isolate it, keep it still, rest, ice, and just do all these very, very traditional things. And it's just like, I feel like it's 2022. There has to be like, there's got to be different ways of doing these things. And when we use this reductionist idea of like medicine, it doesn't really serve the individual and the whole body. And we're obviously just much more than that, just like joint that's got pain. So it's just interesting, like the messages we get from pain. And yeah, I want to ask you about concussions before, because we're coming to the hour point here and I don't want to miss this off, but like, what are some of the key things that people can do with concussions like early? Because I know it's, concussions, and like we've had that movie come out, and I think more people are understanding TBIs, and you've got people taking their kids out of certain sports and things, which is totally up to them. There are certainly more dangerous sports than others, but like, what can people do like kind of like early on in the whole treatment process to really support that healing? And does that differ from a conventional methodology of treatment?
Yes, so it definitely is. If you look at what is offered by a majority of most in healthcare, it is rest. And if you're at 6 months and you still don't feel better, it's rest. And if you're at a year, it is, well, maybe you'll never get back. So that's what a majority do. And that actually doesn't line up with what is called the consensus statement. So every 4 years, the world's concussion experts get together and they create what's called the concussion consensus statement for sports-related concussions. And actually, if you look at the most recent one, or there's one in Berlin a few years ago, and there's a more recent one. I don't know if it's fully been released yet. Right? If you look at their consensus statement, after 2 weeks, 2 to 4 weeks, if an individual is not getting better, they need to seek some sort of care, to have some sort of intervention. Because if it's not going to happen at 2 to 4 weeks on its own, most likely it's not going to, or it's going to take a long period of time, right? That's why after that 4-week period, it's labeled as post-concussive syndrome. So let's take a step back. What happens in a concussion? Because that can let us know what things to do. So on the metabolic side, when we have a concussion, it's like our brain goes from being a fuel-efficient Prius getting 40 miles to the gallon to a gas-guzzling SUV getting 5 miles to the gallon. So one of the things we know is that happens during a concussion is that we become very metabolically inflexible. So our ability to utilize glucose becomes very inefficient. This is why the ketogenic diet has kind of gotten a ton of craze in the TBI community, is that in a concussion, you get the initial hit, and then what sometimes leads to more kind of damage within the brain is that the metabolic instability over the following few weeks. Because then the way you burn through fuel is very inefficient, and so then neurons start going haywire and dying because they don't have stable energy. So one of the big things is keeping blood sugar stable. But more specifically, this is where sometimes we'll use things like the ketogenic diet. So something like a high fat, low carb diet, or we'll use things like exogenous ketones to give the brain a different source of fuel. Now, once again, check with your doctor. It's not for everyone, but that's where certain like dietary strategies can play a role, is you want to stabilize energy, right? So we want things like protein and keeping blood sugar stable. That's one. Another thing that happens is what's called excitotoxicity. So in a neuron, you have what are called sodium and potassium pumps. So the balance between sodium and potassium allow different kind of molecules in, and it allows activation of a neuron. So you get what is called excitotoxicity, where you get this unstable electrical current, in essence, around my neuron. So the neuron electrically becomes very unstable. And this is where, in severe cases, you see things like seizures, right? This is why seizures occur post head injuries, is because of the excitotoxicity of the brain. What's really cool is going back to ketogenic diets can actually increase the amount of GABA, which is an inhibitory neurotransmitter. So ketones and ketogenic diets can help to improve excitotoxicity. From a supplemental form, this is where things like magnesium threonate and magnesium glycinate can actually be really helpful, because that magnesium acts as a plug on that channel to help slow down that excitotoxicity. So once again, we have some dietary strategies. Things like magnesium can be helpful in limiting that excitotoxicity early on, okay? And then we have inflammation that occurs. So we know that when a head injury happens, we get a ton of inflammation, which is normal, but we don't want too much inflammation. So this is where having an anti-inflammatory diet is really, really important. The most researched supplement that I'm aware of and the safest for inflammation post a head injury is actually fish oil. So fish oil, things like EPA and DHA, anywhere between 2 to 4 grams, has some really cool research in turning off the inflammation or helping to resolve the inflammatory response. Because when I have a concussion, I get inflammation, but then I need to have anti-inflammation to then resolve it. In some people, it just stays going like that. So we have energy imbalances, right? Mitochondrial dysfunction. We have excitotoxicity, or too excited of a brain. And then we have inflammation. So that's where having an anti-inflammatory diet, things like omega-3s, magnesium can be helpful early on. That's also where, within the first few days, like paying attention to your threshold, right? You want to get back to living your life, but think about it. If you have that unstable neuronal pool and you go to a rave 2 days after and there's flashing lights, you're going to cause most likely more damage, because you're forcing those neurons to work harder than they're capable of doing. So rest does have its role. I always tell people, if something increases your symptoms more than 2 points, so let's say your headache is a 2 out of 10, and you go to a movie and now it's a 5 out of 10, that was too much. If it goes up by maybe 1 point, then that's okay. That's not that big of a stimulus. Like, you can handle that. And then the last piece is blood flow. So this is where I love exercise. The faster someone can get back to exercise, the better. Exercise is like medicine for concussions, because it helps to re-normalize blood flow within the brain. So we know that post-concussive syndrome sometimes is theorized by inefficiencies in blood flow in the brain. So the ability to regulate blood to different areas becomes affected with concussions, and sometimes that doesn't re-normalize. And this is why individuals have headaches maybe months to years after. And there's some really cool research on aerobic exercise, more specifically subthreshold, or what you would think of as like zone 2. So like some might think of as zone 2, some might refer to it as like a ventilation threshold. So at a pace where you can maintain a conversation. So with individuals, as soon as we can, we do what's called a Buffalo concussion treadmill or bike test. And this is where they hop on a bike or a treadmill, and we find at what point cardiovascularly do they aggravate their symptoms, and then we take a percentage, and then we have them work at that heart rate. And they'll do at 80% of that heart rate for 2 weeks, 20 minutes, 5 times a day, or 5 times a day, 5 times a week, and then we reassess it in 3 weeks and we build threshold. So what we're doing is we're using exercise to re-normalize energy within the brain, but also to improve blood flow. So those are some kind of things that people can think about early on. And I think my big key other as well is um, get assessed. Go see someone who specializes in this arena, and don't wait. If you're at a month and someone's telling you rest more, no, that's the point you need to go see somebody. If you're at 6 months and they're just telling you to rest, more rest is not going to do it. If rest was going to do it, it would have done it within 2 to 4 weeks. So I think my thing is be proactive and be an advocate for yourself and get to someone who is trained in understanding concussions and how to treat them.
That's cool. Yeah. I mean, it sounds like a delicate yet active approach, because obviously
Mhm.
we don't want to just like sit and do nothing and sit in the dark, and
Yep.
and that can obviously bring on depressive symptoms and spiral that process even
Mhm.
further. And I'm sure the idea of getting back to movement, getting back to like normalcy is just as much as part of the healing process as actually like consuming foods that are anti-inflammatory and doing all those other extra things. So that's really great. That was a really great assessment there. I appreciate it.
Yeah.
How can people learn more about your practice and connect with you?
Yeah, definitely. So our website is Integrated Health Systems, and we actually offer like free 30-minute consults, which are actually a great way for people to call, learn a little bit more about us, and also we kind of review cases. Sometimes we even work to find people in their area. So I know people in Canada, I know people in Europe, in Australia, all around the country. So it's also helping to get people to the right places. I have social media as well on Facebook at dr.perry.maynard, and then on Instagram at Dr. Perry Maynard, where we're posting free webinars, free educational content. We usually do free webinars kind of once a month on various topics. So I'd say those are the main areas people can connect with me. And then the last two are we were recently a part of two books called the Concussion Discussion, and it was a book written by myself and a variety of other doctors about innovative treatments for concussions.
Beautiful. Well, I will make sure that all that information is in the show notes so people can connect with you. But thank you so much for your time today, Dr. Perry. I really appreciate it.
Yeah, thank you so much, Simon. It was a great time.
Of course. So that is it for this episode of True Hope Cast, which is the official podcast of True Hope Canada. Yeah, as I said, all the information to connect with Dr. Perry will be in the show notes, so you can get there. Don't forget to subscribe if you haven't yet. iTunes, leave us a review, 5 stars on Spotify if you've got the time. But thank you so much, everyone. We'll see you next week.